Hello everyone. Assalamu alaikum and good morning. Am I audible to everyone? That's great.
Yes, Doctor.
Today, with the support of the Paudi cabinet members and the supervisors of the residency program, especially in the Karachi, we have initiated an academic activity, and today we are holding the first session. We have decided to continue this activity on the basis of the feedback received from the resident, how this is beneficial for them. On the basis of current data, we have decided to start with the journal club article, any article that is the interest of resident, and especially to the topic of endodontics will be presented by the resident, and the supervisor with the resident would be supporting in that activity. And the next month, we are basically would be having any case that has been done by the resident, and with the support of the supervisor, the resident will present, and then critique will be given by the other facilitators or the supervisor from the other centers. So how we will see this is activity going to be beneficial for everyone, then we involve the other centers from the Sindh and then later on the Punjab. So today we have a participant from the JSMU. She is basically doing her residency in final year, Dr. Anusha, under the supervision of Dr. Yavar Ali Abdi, and he is not available in Pakistan. Today, Dr. Maham will be basically joining with her. And I will ask Sharif to give basically the co-host or host right to present her today article. And with the article, if I go through the detail, this is basically a case report based topic, and it's basically the dentine complex regeneration. So it's not a very extensive article, but she has taken a very good topic to present today. And facilitator today we have Dr. Farhan Raza Khan and Dr. Arshad, basically because of some urgent work has excused. And then I'm really thankful to Dr. Nasir Salim to take basically my suggestion and then join us from the Lahore. And let's start with the activity. Sharif, could you give mic to Anusha to start with her presentation of discussion of the article today that she has selected?
Assalamu alaikum. This is Dr. Aushna. Can everybody hear me?
Yes, we can hear you. Are you going to share any screen or you are going to just...
Yes, I will be sharing the screen.
Okay.
Okay, so I've shared the screen.
Yes, we are basically can see. Can you go through basically the slideshow? That would be more visible. If you go through the slideshow option in your presentation, then it will be
yes, fine.
Good. Yes, this is the great.
Okay, so the topic for today is regeneration of the Pulp-Dentin complex in a tooth with symptomatic irreversible pulpitis and open apex using regenerative endodontic procedures. It's an article from Journal of Endodontics published in February 2021. So regenerative endodontic procedures are usually undertaken on permanent teeth with necrotic pulps and open apices. The goals are threefold, including resolution of the symptoms, allowing continued root development and reestablishment of the pulp vitality. The histological outcomes reveal that true regeneration of the pulp-dentin complex is not achieved, however. A mixture of fibrous and mineralized tissues is found within the pulp space. There is no polarization of odontoblast-like cells along the tissue either. Regenerative endodontic procedures have become increasingly popular for the treatment of teeth with necrotic pulps and immature apices with or without apical periodontitis. The outcome studies for REPs compare favorably with the flexification, appearing to elicit greater gains in both root width and length. The aim of the current case report is to present the successful use of REP on a vital immature maxillary central incisor diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis in order to relieve the symptoms and allow for continued root development. So a 9-year-old female presented to the postgraduate endodontic clinic at the University of California, San Francisco with the chief complaint of intermittent and throbbing pain to biting and heat, spontaneous lingering pain to cold at the right and left maxillary central incisors. 4 months ago, she had a history of uncomplicated crown fractures of both teeth 8 and 9 without pulp exposure, and the teeth were then restored with composite resin. Her medical history was unremarkable. The gingiva around both teeth were inflamed, and a sinus tract was noted at the gingiva near the root apex of tooth number 8. The pulp sensibility tests were performed at the appointment and repeated thrice. Tooth number 8 showed no response to both cold or electric heat testing, while tooth number 9 showed a lingering and painful positive response to cold and electric pulp testing. The radiographs in this showed that both teeth had open apices. Tooth number 8 showed a periapical radiolucency associated with the sinus tract as seen by the GP tracing. Tooth number 9 showed a periapical radiolucency around the apex. Both teeth were sensitive to percussion and palpation. CBCT imagery was also used to confirm the presence of open apices and associated periapical pathosis for both. The diagnosis based on these clinical and radiographic findings for tooth number 8 was pulpal necrosis with chronic apical abscess, and tooth number 9, symptomatic irreversible pulpitis with symptomatic apical periodontitis. So after the chief complaint was attributed to tooth number 9 for being symptomatic, the treatment was commenced. Informed consent was obtained from the patient's father. Local anesthetic was administered using 1 cartridge of lidocaine with epinephrine and articaine with epinephrine. Single-tooth Rabadam isolation was done, the pulp chamber was accessed, and the diagnosis of irreversible pulpitis was confirmed as the pulp was vital and hyperemic. The pulp tissue was removed to a level 5 millimeters from the radiographic apex using large K files, and the irrigation protocol consisted of 1.25% sodium hypochlorite, sterile saline, followed by EDTA. The canal was dried, calcium hydroxide was placed as an intermediate medicament. Glass ionomer temporary restoration was used to then fill the access cavity. The patient returned for a follow-up visit after 10 days, and the tooth was now asymptomatic. Profound anesthesia was achieved in the same way with lidocaine and epinephrine and articaine and epinephrine. The tooth was isolated, temporary restoration was removed, and calcium hydroxide was removed by flushing the canal with sterile saline, EDTA, and followed by sterile saline again. Intracanal bleeding was induced using a size 25K file inserted to 4 millimeters from the radiographic apex, and the blood was allowed to reach a level 3 to 4 millimeters from the CEJ. White MTA was placed over the blood clot, followed by glass ionomer and composite to close the access cavity. 3 weeks later, the patient returned and the tooth was asymptomatic. The tooth number 8 was subsequently scheduled for REP after a few months, and the tooth was clinically asymptomatic at the time. Local anesthesia was administered using a cartridge of lidocaine with epinephrine, and the tooth was isolated and accessed, and the diagnosis of pulpal necrosis was confirmed. The working length was determined using an electronic apex locator and confirmed using periapical radiographs. A K file was used for light instrumentation of the canal walls to disrupt the bacterial biofilm. The irrigation protocol consisted of the same 1.25% sodium hypochlorite followed by sterile saline and EDTA. Calcium hydroxide was placed in the canal as a medicament. The access was temporized with a glass ionomer temporary restoration. The patient returned in 3 weeks for a follow-up with the tooth, which remained asymptomatic. Local anesthetic was administered with a cartridge of 1.8 ml, 3% mepivacaine. The tooth was isolated, the field was disinfected with sodium hypochlorite, the temporary restoration was removed, the canal was reaccessed, and calcium hydroxide was removed by flushing the canal successively with sterile saline, EDTA, and sterile saline. Bleeding was evoked from the periapical tissues by taking a 25K pre-bent file past the apex into the periapical tissues, and the blood was allowed to reach into the canal up to a level 3 to 4 millimeters below the CEJ. A pre-measured piece of collar plug was placed in contact with the blood clot. White MTA was placed over it and sealed with glass ionomer restoration. Despite the use of collar plug, MTA was pushed into the canal space in the tooth more than 3 to 4 millimeters below the CEJ. This slide shows the periapical radiographs of the teeth at 6 months, 12 months, and 18-month follow-up appointments after the completion, 18 months after the completion of tooth number 9. This slide shows the CBCT images of both tooth number 8 and tooth number 9. There's a clear difference in both, showing tooth number 8 shows the closure of the apical foramen with hard tissue deposition up to the level of the MTA at 12 months post-op. While the CBCT for tooth number 9 shows closure of the apical foramen with presence of soft tissues within the canal space up to the level of MTA. The patient had presented to each appointment without any significant concerns and symptoms associated with either tooth. Sensibility testing was performed at each appointment and revealed a positive response to cold and electric testing in tooth number 9, while there was an absent response in tooth number 8. The patient was placed on a follow-up schedule to examine for evidence of pulp regeneration. This case report is the first example within the literature to directly apply a similar procedure for the treatment of a vital inflamed pulp on an immature tooth to that which was modeled recently in ferrets. In ferrets, pulp from healthy immature cuspids was amputated 1 to 4 mm from the apex, bleeding was evoked, access was sealed with MTA and compared with controls. The histological results revealed that normal pulp regenerated coronally towards the formation of a hard tissue bridge apical to the MTA. The significance of this shows that the use of REPs above amputated pulps in teeth with symptomatic irreversible pulpitis and open apices has the potential to regenerate a normal Pulp-Dentin complex. In the present case report regarding tooth number 9, a similar clinical procedure was performed with the exception that the tooth was irreversibly inflamed. Histological samples were not obtainable, although there was evidence of continued root development. All symptoms had resolved and the tooth presented with normal responses to pulp testing upon follow-up. So 3 separate case reports have also been done to show the regeneration of pulp-like tissue in immature teeth. The first was by Torabinejad and Faras. The diagnosis of the tooth was pulpal necrosis. The tooth underwent REP with PRP as a scaffold material. On turning symptomatic, the tooth needed a root canal, allowing a histological sample to be taken. The findings showed pulp-like tissue devoid of odontoblasts, and it was hypothesized that the PRP facilitated the stem cells to migrate from the remaining pulp tissue, allowing the formation of the pulp-like tissue. The second was by Shimizu, and as claimed by the article, it is most similar to the current case report. The diagnosis was irreversible pulpitis after traumatic pulpal exposure. Incomplete removal of pulp tissue via deep pulpotomy was performed. Ensuing REP was extracted due to further fracture and being deemed non-restorable. The histological analysis showed tissue consistent with immature pulp within the canal space, polarized odontoblasts observed over the pre-dentine. The potential reasons for formation of the pulp-like tissue could be residual apical pulp tissue during REP or the proliferation of the apical papilla into the canal space. The third was by Peng et al. The diagnosis was symptomatic irreversible pulpitis. The radiographic examination after 12 months showed thickening of the root canal wall and lengthening of the root and narrowing of the root apex. The histological examination showed regeneration of pulp-like tissue apically and cementum-like tissue more coronally. The explanations for this non-uniform tissue regeneration could be either uncontrolled manner of pulp tissue removal, use of highly concentrated sodium hypochlorite, and loss of temporary restoration between appointments. The procedure described for tooth number 9 in this case report is an extension of current regenerative endodontic procedures and current vital pulp therapy techniques. So there is a hierarchy of goals established by the AE to consider REP successful. The primary goal would be elimination of symptoms and evidence of bony healing, then increase in root wall thickness and or length, and a positive response to vitality testing. Vital pulp therapy, specifically pulpotomy, is the removal of the coronal portion of vital pulp tissue to allow radiographic evidence of continued root development. The AAE recommendation states that pulpotomy performed on a permanent tooth is an interim procedure. However, no further treatment may be required, assuming proper restoration. The success rates for modern BPT are possibly due to the improvement of materials and a better understanding of pulp biology. Increasing the use of BPT for treatment of irreversible pulpitis forms the basis of the term minimally invasive endodontic. This term is centered upon the idea that the reversibility of inflamed pulpal tissue exists concurrently when a diagnosis of irreversible pulpitis is established. A guideline has been established for the treatment of deep caries using VPT when appropriate, and it is supported by histological examination. And it shows that VPT allows the maintenance of the pulp-dentin complex applicable to the pulpotomy site. However, there is morphological changes to the radicular pulp. The use of MTA as a direct pulp capping material is effective during the 2-visit treatment protocol when the pulp is exposed during caries removal. 53 cases followed over a time period of 9 years post-treatment. 98% showed a positive outcome, including continued vitality, and 100% of immature teeth showed continued root development. To conclude, in the majority of cases in which historical samples are available, the tissue formed after RET is not normal pulp tissue, but rather a mixture of bone, dental hard tissues, and fibrous tissue. However, the formation of normal pulp tissue may be possible for the procedure described in this case report for tooth number 9. The limitations of this study could be that the procedure for both teeth could have been initiated currently because tooth number 9 was symptomatic and started before, but tooth number 8 had a sinus tract associated. And since histological analysis was not performed for the teeth, there is no way to actually find out the difference in the character of the pulp tissue formation. Some points to ponder would be the CBCT image of tooth number 8 showed hard tissue closure of the apical foramen. However, the aim of RET is soft tissue growth. And even with the placement of collar plug, the MTA was pushed 3 to 4 millimeters past the CEJ. So why was it not retrieved? Collar plug was only used in one tooth, tooth number 8. Was there any specific reason for not using it in tooth number 9? Since calcium hydroxide, EDTA, and sodium hypochlorite came in direct contact with the pulp tissue in tooth number 9, did it have an effect on the outcome? There's no way to find out, so that, again, there was no histological analysis. The study cited by Torabinejad and Firas shows no direct correlation with the current procedure since the tooth was necrotic and BRP was used as a scaffold material. The study cited by Shimizu, which according to the article is most similar to this procedure, involved complete pulpectomy after the diagnosis of irreversible pulpitis was made, and a high concentration of hypochlorite was used, and bleeding was induced from the periapical tissues rather than from the activated pulp. This study also leaned towards traditional REP. One advantage that could be seen was there was no manipulation of periapical tissues in tooth number 9, hence the local anesthetic regimen was not altered. Thank you.
Very well presented, Ushna. And now I will give mic to Dr. Nasir Salim, so he can share his thought regarding this article.
Thank you, Dr. Robia. I was having trouble unmuting myself because probably I did not have the feature. So thank you so much, Dr. Ushna. I think it was a very nice article. There are a few things that I would like to say about this. I think it was very well presented as well. Before I say anything, I would just like to make a mention of the wonderful initiative that Khan faculty and especially Dr. Robia has taken to actually start this activity to bring so many people across Pakistan on one forum. I think it's an absolutely wonderful activity. I would also like to congratulate Dr. Abdi, Dr. Yawar and Dr. Maham for taking the initiative and presenting their postgrad resident to be presenting in this particular activity the first time. It's amazing. Okay, So coming on to what we are here for, first of all, as long as we understand, and I think being a fourth year resident, you do understand that it's a case report. So of course, the level of evidence is where it stands. It's not a very high level of evidence. But at the same time, there is novelty associated with this treatment. And I think that is precisely the reason why, Ushna, I'm just reading your mind. You probably chose this topic for today's General Club. As I was going through this topic, the first thing that hit my mind was that this is basically, and the author at the very end, when he makes those recommendations for future directions, they mention that this is a treatment that may be used eventually as an alternate to RCT for closed apices and shallow or deep pulpotomy for open apices. So we are all pretty familiar with Swex pulpotomy and deep pulpotomy for cases in which you have fractures or, even exposures in which the pulp has not been exposed to environment for more than 24 to 48 hours, assuming that the inflammation is in the topmost portion only. So it's more of an alternate to that. And when you start mentioning the name regenerative endodontics, the first thing that comes to my mind, or the first thing that comes to anybody's mind, is a necrotic tooth, an open apex, probably an apical periodontitis, and then the whole process of regenerative endodontics. So it's slightly different from that, and that is where the novelty comes in. You just have to eventually be making the right selections for the case selection, because many of these cases, like I can argue that this particular case, tooth number 9, could have been treated with a deeper pulpotomy, and probably it would have led to, I can only assume, but it could have led to all of the following outcomes that they eventually achieved: a closure of the apex, probably more dentin being formed, as well as the vitality being maintained, and eventually your ability to actually check the vitality. So this is just another way of treating similar cases. The only thing that I think probably the authors were thinking was that in cases where there is a leakage of a previous restoration leading to irreversible pulpitis, you can't really make sure how deep the inflammation is. And that is why they wanted to go in about 3 to 4 millimeter short of the apex and amputate the pulp, so that they are taking care of all the bacteria, or if there is any bacteria or the inflamed tissue, and then going ahead, so sort of creating an aseptic environment, and then creating that blood clot to give rise to that regenerative part of this treatment. So that is, I think, the mindset, or the from where this treatment is coming, I think. Okay, there's a slight difference. Ushna, are you with me?
Yes, I am.
Okay, Ushna, so did you see that there was a difference in the protocol that was used in the ferret studies to what they have used over here? And I'm so sorry if you have already mentioned that, because my internet was unstable. So I chose to now come to my mobile. So I may have missed something at the very end of your presentation. So is there any difference between the ferret studies and the protocol that they have used here in this human case report?
The protocol for the ferret study and number 9 is the same.
Yeah, but as I was reading that ferret study, what they did was that when they amputated, they did not do any kind of irrigation afterwards. In fact, the whole act of amputating was used as a means of promoting the blood clot, and hence, then sealing with the empty and eventually regeneration occurring. Whereas in the human study or the case report, what they did was they amputated, then put calcium hydroxide, then went in again and started the blood clot. So that is a little bit of difference from the animal model that they have based their study. Just for academic reasons, I wanted to discuss with you. Do you think that is the difference between the two? Or maybe I read it wrong?
No, that is the difference between the two.
Okay.
There was no use of an intracanal medicament and no use of irrigation. So it didn't actually come in contact with the amputated pulp tissue.
Yeah, and then Ushna, I would like to talk to you if that is okay with you. It's fine, and I think the others can hear, and I can then direct it to someone else as well. So Ushna, he does want to make a comparison between, because he was in this wonderful situation where two teeth that were adjacent to each other had, one of them had a necrotic pulp, and what you should call it as a conventional regenerative procedure was carried out on that one. While in this particular one, he was, going for what may be prescribed as a new way of vital pulp therapy. So he was trying to compare both of them, and he does make a conclusion that एक के अंदर जो है, he had more of a pulp-like tissue, good amount of pulse space evident in the post-op, CBCT, while in the other, there is very little pulp tissue, rather it's more calcified tissue. How much do you agree with this observation and this comparison that he makes, Ushna?
I agree with that because it's also mentioned in the study. There was a calcification of the tissues due to, I think, deep placement of MTA in tooth number 8. However, there is a lot of pulp-like tissue in the canal in tooth number 9.
Yeah, but could that be because in the case of tooth number 8, he goes very close to the pulp, to the apex, like inadvertently, probably the MTA gets pushed pretty close to the apex, and we know that whenever this pulp tissue is formed within the pulp, closer to the MTA, it is more of a calcified tissue. It's a slightly different tissue. So could this not be a very good comparison? Had the MTA position be exactly the same or more or less the same in both the teeth, probably that conclusion would have been a more logical conclusion to draw, or do you differ from that?
No, I agree with your opinion that the placement of the MTA had affected the outcome in this case.
Yeah, that's nice. And in the Farad studies, they went ahead and they did both the 1 to 2 millimeter amputation close to the apex and 3 to 4 millimeter amputation. Was there any difference between the two? Because they had 4 groups in that. There was a control, positive control, a negative control, and then there were 2 groups in which in the Farad study, they had done a 3 to 4 millimeter amputation and a 1 to 2 millimeter amputation.
Yeah, but I don't think there was any difference.
Yeah, there was only one, probably not exactly failure, but not the same kind of pulp tissue that was generated out of the 7 cases, while in the 3 to 4 millimeter group, all 7 had pulp-like tissue generated within the pulp. Okay, Ushna, one last thing from my side, and let's just I would imagine you would appreciate that it's just a discussion. I'm not trying to question. If we both have a discussion, probably that who are logged in right now, rather than I hope you are confident. A yes would do.
I'm sorry, I did not hear anything. I don't think the internet was working. Could you repeat that?
No, I just asking you, is that okay with you?
Your voice is not clear, sir.
Yeah, your voice is breaking up, Dr. Nasir.
Me asking you a few questions and clarifications. Is that okay with you, right? Okay, I guess there is some lag or oh, sorry. So I would like to speak slowly. The last thing which I would like to discuss with you, I am so sorry, I am at the mercy of initially the college internet. So now I'm on 3G. I would just sign out. The last thing I don't know. Farhan, can you hear me, please?
Yes, now we can hear you.
Okay, if I can make the last point in which, Ushna, you were saying that there have been various animal studies that have, given a final conclusion that after the conventional non-vital, pulp regenerative therapies, you get a cementum or a bone-like or a calcified tissue. But then this article mentions a very weak evidence, but 3 case reports in which in humans, when similar procedures were carried out, there was pulpal tissue regenerated in humans in those case reports where, for whatever reason, either the tooth had to be extracted or root canal treatment had to be carried out post a regenerative procedure. And so that gave the authors the chance to histologically examine, and eventually they found out that there was pulp tissue in humans. So just keep that in mind as well while trying to deduct the base of your knowledge from those animal studies. My final comment, wonderful job, Ushna. Wonderful job, Dr. Robia. Over to Dr. Farhan, please.
Thank you, Dr. Nasir. Thank you. And I was wondering, when your voice was breaking, the only thing we could hear was sorry, sorry, and apologies. So was that a coincidence, or it was your phone was just habitual of hearing this thing? So apart from that, is my voice audible?
I can only hear sorry.
Yes, sir.
Yes, audible.
Yes, sir. You are clear, sir.
Okay. So thank you, guys. I'm happy to see that over 70 participants have joined. So first of all, I would like to congratulate Dr. Robia for taking the initiative from the platform of PAUDI. Such journal clubs are a great activity because it inculcates the ability to critically analyze the literature so that we do not accept things on their face value. We need to evaluate the evidence and critically appraise them and take up what is important and improve our practice in light of the evidence, right? So these journal clubs are great activities, and from the PAUDI's platform, we are also, contributing at the APAC journal club, usually taking place at the Tehran University of Medical Sciences. And in future, I would expect that such journal club activities would be expanded and more participants would be, actively getting involved in such activities. So coming back to the paper, there is like the first and the foremost comment when I noticed this paper was that for journal clubs, it would be better that if we select papers with data, trials, prospective studies, retrospective studies, charts reviews, cross-section studies, or the studies that are, that have meat when you critically analyze them because of the numbers. You can comment on their study design, their methodology, outcome assessment, their analysis, statistics, sampling strategies, sample size calculation, power analysis, and etc. With case reports, the critical appraisal gets very narrow. So that is the advice for my future colleagues, participants, and journal club attendees, that if you were to select a paper for journal club seminars and critical appraisal sessions, please try to select papers which are not case reports and not case series, right? So that's a suggestion. Now, coming to this particular paper, I noticed a couple of things that if I were the clinician, I would not have done. For example, they have like 2 teeth, one tooth number 8, the diagnosis of pulp necrosis and periapical abscess, asymptomatic, though presented with a sinus. And tooth number 9, that is maxillary left central incisor with irreversible pulpitis and apical ptosis. Now they chose to treat tooth number 9 first, knowing that there is an adjacent tooth with a sinus and it was left for a couple of months. So if you were the treating clinician, would you have preferred to treat both teeth together, provided both were indicated for treatment? And if you were to plan regenerative procedure, it would be better to carry out both procedures together and give one anesthesia at one time rather than scheduling the procedure again and subjecting the patient for an intervention at another time where that she could have presented with an acute problem later. So was that an ethical thing to do? Or if you were the treating clinician, how would you have approached the case? So that's my first question.
So I've also mentioned these two points at the end of my presentation. As the treating clinician myself, tooth number 9 was symptomatic, but I would have preferred to treat both teeth together to increase patient compliance and to reduce the patient visits and anesthetic use as well.
Okay, so my second question is they have used local anesthetic with epinephrine in them. Do you think it was a right choice of using epinephrine when they were aiming to initiate bleeding, especially on the second entry?
In traditional RET, it is not recommended to use anesthetic with epinephrine. However, I don't think they were manipulating the periapical tissues, so that's why they used epinephrine. I'm not too sure about this, but they were trying to avoid bleeding. So.
Okay, for regarding tooth number 9, since it was necrotic to begin with, do you think they could have, resorted to using triple antibiotic paste or any other antimicrobial to maintain sterility and to maintain to ensure cleanliness in tooth number 9 canal? What are your thoughts on that?
I'm not sure because again, they could have used it, but it would have come in contact with the pulp tissue as well in tooth number 9.
Okay. With the radiographic outcome of tooth number 9, do you think that tooth could be radiographically successful? In clinical sense, yes, it is successful. There are complete resolution of signs and symptoms. But radiographically, if such tooth gets symptomatic, let's say 10 years down the road, would it be easier for the treating dentist to treat such a tooth number 9 especially?
I'm not too sure.
Because one of the untoward thing with regenerative procedures and use of MTA and all that is the continued calcification. Since it's just 1 year follow-up, let's say 5-7 years down the road, the apical part that of tooth number 9 gets sclerotic or over calcified. So in that context, would that tooth still be labeled as a radiographic success, or a simple root canal treatment, which has a known success rate and a track record of being successful in such situation, would have been a better choice? So what are your comments on that approach, the approach they have taken for tooth number 9, especially with the inadvertent pushing in of the MTA deep into the canal space?
Dr. Farhan, can I just clarify? I think you're talking about tooth number 8, just for everybody's.
Oh, yes, tooth number 8. Sorry, tooth number 8, upper right central incisor.
That's why I was a bit confused. Because I think the apical tissues have calcified, I think it would have been better to perform either retrieve the MTA or perform traditional root canal in the future if it becomes symptomatic.
And lastly, while observing all the radiographs, the ledge on the distal aspect of tooth number 8 continued to give me, an optical tension. They have noticed that there is a ledge of composite you know, in the coronal third on the distal aspect of tooth number 8, but nobody bothered to just so flex it. So which means that the endodontists pay more attention to the pulp-dentin complex and then don't pay attention to a faulty restoration. Have you noticed that?
I just noticed that right now, yes.
Okay, since it was a case report and there is not much to critique on it except for the technique and the approach they have taken, and since you have just, you know, a single case with 2 teeth, so there is not much, you know, substance to question upon. So I would like to thank you, and it takes a lot of courage and it takes a lot of guts to present the case. And I know that these are not your cases. These are cases taken from the literature. So you're not accountable for the quality of treatment rendered. But even then, it takes a lot of courage. So I must congratulate you, and I'm happy that Dr. Yawar and Dr. Maham have supported you. So thank you. That was all from my side. Thank you. And now over to Dr. Robia. Thank you.
Thank Dr. Farhan and Dr. Nasir for the very nice comments. We have a very few questions from the resident, and I will encourage the resident to take questions from the basically speakers, so they have clarity in their thought process. So first, there is a question from Dr. Zainab. So I will ask her to proceed.
Thank you, Dr. Rubio. Firstly, I would like to congratulate the presenter, Ms. Oshna, and she presented quite well. I think my question was also asked by Dr. Farhan regarding the thoughts about using the anesthetic protocol with epinephrine in the second regenerative visit, because as we all know, the literature does say that it induces or it supports the vasoconstriction. So I do not understand why did they use it even in this case specifically if they had planned on having a successful outcome. So that was just one of my questions. If anybody can shed light, that would be great.
Assalamualaikum, Dr. Maham here. What we also pondering on this question similarly कि क्यों नहीं use किया उन्होंने without epinephrine, but the only logical explanation we could come up with was that maybe because they weren't manipulating the periapical tissues. The bleeding that they were inducing was from the apical 3 to 4 mm of the pulse space. So maybe that might be one of the reasons that they did not use local anesthetic without epinephrine. But that's an assumption. Yes.
Yeah, ma'am, and thank you. An alternate explanation could be कि उनके पास एक ही तरह का anesthetic था, epinephrine वाला.
Sir, नहीं था क्योंकि number 8 में they used one without epinephrine. They used I think mepivacaine use किया उन्होंने, number 8 का किया था उन्होंने second visit में.
में भी कई दफा कई महीनों available नहीं होता, तो I think that's a more logical.
More logical thing.
But they were not manipulating the apical tissue. Na? They were retaining the 3-4 millimeters
I do
of the
agree with
micropulse.
that. That might be the thought process. Might be.
So then again,
Actually,
they
we're
have used it in
speculating on
one,
behalf of the
and,
authors.
Also, they did not mention anything about that in their discussion. They should have if there was anything that was on their mind.
Yeah, there are quite a few things that you could clinically, put a finger to. Even just Dr. Farhan mentioned that I did not go in that direction. जो GP tracing है वो भी first visit से नहीं available. वो जब से एक महीने के बाद patient बाहर से घूम फिर के आ गया तो उस वक्त का GP tracing है जब साथ वाले दाग के अंदर they had already started VTP और जब भी आप उसको चाहे regenerative कहना चाहें, जो भी इस procedure को नाम देना चाहें. So there are a few lapses in the reporting of the case. Some clinical pictures of this could have actually helped. I do understand that journals only allow certain number of pictures, certain journals, तो उस वजह से भी दुश्वारी हो सकती है. Yeah, but that picture that was shown as a pre-op picture by Dr. Sabeti presenting probably 6 months later picture when one treatment had already gone in. And I think the first thing that came to everybody's mind was, why not start this adjacent tooth as well at the same appointment? But then I probably, Dr. Farhan, I can only speculate because the authors are not here. So we can only speculate on their behalf कि पोस्ट ग्रेजुएट रेजिडेंट लेने के अंदर हो सकता है उस वक्त उतना ही टाइम हो जिसके अंदर उन्होंने वो वाली ट्रीटमेंट रेंडर की, एंड यू नो इट कुड बी द स्केड्यूल बिकॉज़ दे डिड मेंशन कि पेशेंट बाद में एलोप हो गया एंड केम बैक।
सर एक बात बताएं, ना फाइलिंग करनी है ना कुछ, सिर्फ थोड़ा सा छेड़ के ब्लीडिंग इनिशिएट करके ऊपर से बंद ही करना है।
सर सारे लोग आपकी तरह 40 प्रोसीजर दिन में नहीं करते ना, कुछ लोग मेरी तरह लेड बैक होते हैं, पहले बंदा भेजते हैं कि जाओ जाके देख के आओ, एनेस्थीसिया लगाओ, फिर काम शुरू करेंगे।
I think this is the problem when we are discussing somebody else's article. We don't know what was the scenario, what was the situation behind it, and we are
reality.
getting all the answers from ourselves. So we have a hand raised by Dr. Javeria.
Okay. Assalamu alaikum, everybody. Very good presentation. My question, or you can say, I need to ask to everybody who can answer this, why they have just left apical 4 millimeter? I mean, they could have left 1 to 2 millimeter or a 3 millimeter. Is there any specific reason for that 4 millimeter? Did they find a vital tissue over there? But they have already mentioned that it was a necrotic pulp. It was a case, and the tooth was not vital. So I was just thinking, what was the reason for leaving 4 millimeter there?
I think if I can take that question, it was a vital tooth. That's why it had irreversible pulpitis. So मेरा ख्याल ये है कि इस वजह से 4 millimeter, because they were basing it on an animal model study जिसके अंदर they had a slightly better result with a 4 millimeter plug left behind.
Or they found bleeding over there, or what? Just like the हम अगर vital pulp therapy का protocols देखते हैं कि in deciduous teeth, तो we first clean with the sodium hypochlorite. If the bleeding stops, then they go towards vital pulp therapy या जो भी procedures हैं, वरना अगर bleeding stop नहीं होती, go for pulpectomy. So was that the reason?
No. This is totally. You're probably talking about a deeper pulpotomy or a shallow pulpotomy.
Yeah.
You'd like to see if the bleeding stops. That might be an indication that there's no inflammation at that point, or that might be an indication there's necrosis beyond that point. So it's a clinical decision based on that. That far beneath the probably that differentiation is difficult, and that is what the problem that I had with the clinical protocol taken in this particular case, because in the animal model study, they admitted that जब आप 4 millimeter plug के ऊपर amputate करते हैं, तो it's not difficult. It's very difficult to control the bleeding. So they just amputate, remove the pulp from the top, and in the same event, that is taken as a promotion of bleeding, and then they put MTA on top of that. But here,
that I understood. But that was an animal model, right? But when they were working on humans, मतलब ये तो मतलब treatment जो है वो humans पे हुआ है. So animal model पे ठीक है, then उनके कोई अपनी reservations होंगी या जो भी चीज थी, मतलब was it necessary to exactly copy that? That was my question. मतलब कोई, is there any specific reason for leaving that much amount of pulp tissue? That was my query.
Okay. As I understood, as I was reading the articles that were being referenced in this particular article, ये पूरी सीरीज चलती है, इन्हीं ऑथर का एक पीछे ये एनिमल मॉडल है, और उससे पीछे एक एक्सीडेंटल केस रिपोर्ट है जिसके अंदर एपिकल टिश्यू थोड़ा सा रह गया था और बाद में पता चला कि उसके अंदर पल्प जनरेट हो गया था. Probably that gave him an idea कि if you leave 3 to 4 millimeters of or whatever amount of pulp in the apical area and use that to promote bleeding, then you have a greater chance of promoting a pulp-like tissue within that regenerated area rather than a more calcified cementoid or bone-like.
Okay, if we take it like that, हम अगर ये कहें कि the apical 4 millimeter will have more cells if we take it like that, ठीक है, कि angiogenesis ज़्यादा होगा, हमारे पास blood सप्लाई ज्यादा है, हमारे पास उसके साथ सेल्स ज्यादा आएंगे. So why not we left more pulp tissue so that more rapid regeneration would have taken place?
Exactly my point. I thought this could have been, and can I, Dr. Zaveria, I wanted to ask Dr. Farhan a question because I like asking questions from him. Farhan, if you were presented with tooth number 8 in your surgery, sorry, 9, and forget about tooth number 8, my simple question is, what would you have done? What would you
A simple root canal treatment, sir.
What?
Predictable, टिकाऊ, देर पा, पायदार.
But anyone else who begs to do, and wants to do something else?
So for tooth number 9, my treatment would have been more predictable because tooth is necrotic, and I would never want to have a pulp-like tissue. And ताकि future dentist को धोखा देके इतना सा pulp लाके कुछ नहीं मिलेगा. I would just do a root canal. Albatta for tooth number, the necrotic tooth.
I'm
for the
asking about
necrotic tooth.
9, which was vital. मैं उसका पूछ रहा हूँ.
अच्छा, vital tooth की बात कर
आपका
रहे हैं.
8 9 उल्टा हो गया.
सर उसकी वजह ये अमेरिकन सिस्टम हम फॉलो नहीं करते ना. हम 1 1 1 2 होता तो इजी हो जाता समझाने. Okay, so this American system is quite confusing. For let's say for upper right one, the necrotic one, I would do simple root canal treatment, and for the one with the open apex, I would have attempted a more conservative approach.
Yeah, so pulpotomy, a deeper pulpotomy. So Dr. Javeria, जो आप बात कह रही हैं कि 4 मिलीमीटर ना छोड़े, थोड़ा और छोड़ दें, तो that's deeper.
यही तो मैं कह रही हूँ ना, because मैंने खुद ही अपनी एक छोटी सी स्टडी मतलब खुद परफॉर्म की थी, जो मेरा आर्टिकल जेईई में पब्लिश हुआ है. So the problem is, अब जितना पल्प टिश्यू होगा उतना रिजेनरेशन के चांसेस बेटर हैं, because more cells, more angiogenesis, जितनी भी सारे फैक्टर्स हैं. So मतलब why not leave more pulp tissue inside अगर करना ही है.
Yeah, that's what I'm saying. It would be a deeper pulpotomy then, which is fine. And science develops when people try new things. Very nicely dropped in JOE article. Immediate respect from my side, Dr. Javeri, on a lighter note. But yeah, you're right. I agree with you. No problem with that.
I think one of the reasons they went 4 millimeter to the apex is that apical papilla is rich of stem cells. About 8% cells in dental pulp are stem cell-like, mesenchymal stem cell-like potential, and they're more concentrated in the apical area. So probably that's the reason they went in there. Otherwise, pathological है conservative रहे और shallower pulpotomy करें, and that's it. MTA तो है आपके पास.
For most cases, that would have achieved the same results. We can only assume. You would have the length of root, you would have development of more dentine, you would have the vitality still intact. So that, yeah, I think it's just another way of, and sometimes and eventually
following
following
the philosophy of minimum intervention, yeah, people would have, selected that.
In a direction where you would have an irreversible pulpitis tooth with a mature apex, and you try doing that in that particular tooth to regenerate and which he mentions at the very end of the article, in which case it would be a game changer if it ever goes down to that. Yeah, so that
again coming back to the discussion, Dr. Farhan, you were there at the Dental Club on Saturday. There was a long discussion on sensibility and vitality. So here also, if they're saying they have regenerated, if they are saying they have regenerated a pulp-like tissue or a pulp, so I guess a vitality test would be a better indicator, or a sensibility. That I'm confused also.
Just with the single test is difficult because there is not a perfect correlation among tests. A point. The second thing is, even with the right central incisor, tooth number 1 with a big amount of MT and a restorative present in the tooth space, in the canal space, it will be difficult to elicit any form of pulp sensibility test down there.
Exactly.
So you will get false negative results if one tries to get a test there. So this is one of the limitations of pushing too much material inside the canal space.
And unless they do a histological test, they can never be sure whether there was in this particular case. They're only based on the assumption of the previous animal models and stuff that this is a pulp tissue regenerated and not like many other regenerative therapies, the bone and the stuff.
सर मोस्टली तो एक फाइब्रस टिश्यू ही ग्रो करता है, फाइब्रोब्लास्ट वगैरह ही ग्रो करते हैं, बिल्कुल उसका टिश्यू आर्किटेक्चर वैसा तो होता ही नहीं है जैसा कि होना चाहिए था, बिकॉज वो एम्ब्रियोजेनेसिस के नतीजे में तो बना नहीं है, वो तो एक तरह से स्कार टिश्यू लाइक टिश्यू होता है, फाइब्रस रिपेयर टिश्यू, जिसमें बाकी चीजें भी ग्रो हो गई तो हो गई.
Histological examination कर नहीं सकते, so they can never be sure whether the claim that they are making based on their assumption is right or wrong.
So you know what? There was an endodontist who used to visit us from abroad. He used to say, "Why you people make big issues out of small tissues?" तो वो फाइल के साथ लिपट के जो आपको एक्सट्रपेट करते हुए टिश्यू फेंकना होता है, उसको रीजनरेट करा रहे हैं छोटी छोटी स्पेसेस में, और आखिर में कैल्सिफाइड ही मिल जाता है, और यू नो.
और लेटर ऑन हिस्टोलॉजिकली भी अगर ये कभी देखेंगे तो इनको मिड थर्ड का चेक करना पड़ेगा, क्योंकि एपिकल थर्ड में तो अभी भी पल्प है मौजूद. देयर इज अ पल्प, सो विल बी वेरी
because of the
डिफिकल्ट.
large amount of restorative material and MTA in the canal space,
yes,
it will be difficult to elicit any form of test. So अगर है भी तो उसको elicit करना problematic होगा. तो वो बहुत अच्छे से execute नहीं हुआ वहाँ पर right central incisor tooth number 8, अच्छे से execute नहीं हुआ वहाँ उसका treatment.
We have a question from Dr. Sakib.
Sakib का हाथ थक गया.
Assalamu alaikum everyone. So thank you Dr. Ushna for such a nice presentation and presenting in such a large forum. So my first question was, I think it was already addressed by Dr. Farhan.
Sakib यार हाथ नीचे कर लें फिर. Dr. Farha I think has a raised hand as well.
मैं जबरदस्ती नीचे कर देता हूँ हाथ, ये देखें.
जी देखें ना, आपके जितने ट्रेनीज हैं इनको वही सवाल ज़हन में आते हैं जिनके जवाब आप पहले दे चुके होते हैं. ये पास होने के तरीके हैं सर.
नहीं सर, वो पेपर हम पहले ही आउट कर देते लगता है. सब एक फ्रीक्वेंसी पे.
So sir, my first question was that how did the vitality testing, because the coronal portion was devoid of pulp tissue. So as I agree with Dr. Farhan that it might give false negative or false positive results. So my second question was that in tooth number 9, which is necrotic, and they did apply cola plug and then pushed the MTF to 3 or 4 millimeters into the canal. So I think which is against the AE protocols. So the reason for placing the cola plug is that the MTA get not pushed into the middle third of the canal, and you might have get thickness, continued dentin thickness in that portion. So if you can compare the picture, you can see that in tooth number 9, the dentin in the middle portion is not that much thicker as compared to tooth number 8. So they must have put the MTA, restricted MTA more to the coronal portion. So that might have been helpful.
साकिब आप इतना ज्यादा अपने सुपरवाइजर की तरह सोचते हैं कि आप भी 8 को 9 और 9 को 8 कर रहे हैं. जबरदस्त.
So I'm talking about tooth number 9, sir. That is the necrotic tooth.
That's truth number 8.
यार असल में हम लोग वो 1121 वाले सिस्टम पे चलते हैं ना, ये 8 और 9 ने बड़ा खपा मचाया हुआ है.
So we are over to you. If no more questions, then I think we are really right on time. And
Yes.
I think there is a last question from Dr. Farah.
But right now her hand is.
उन्हें हाथ मैंने नीचे कर दिया था.
Are you here?
Dr. Farhan, thank you. Actually, my hand was raised, but someone asked to unraise my hand, so it
No,
was
no, that's me. That's
forcefully
me.
put
I have
down.
lowered all the hands. जबरदस्ती फुट्टा लगा के सबके हाथ नीचे कर दिए.
Thank you very much. And I think we don't have much time, but I wanted to congratulate Dr. Rubia and Dr. Oshna and Dr. Maham for taking the lead in starting this very good opportunity for learning. I just noticed two things that I thought that they were not mentioned over here. There was a reference for REP guidelines from American Association of Endodontics, and they cited it as reference number 16. And when I was just looking at the references, it's not correct. This guideline is mentioned in either 17 or 18. So that means these minor mistakes also can happen in journals like these as well. And there's another observation that I was noting, that at the time when the tooth number 8 was, they have shared a radiograph in which they have traced the sinus tract of with the GP. The root closure is already done in tooth number 8 at that time. And when the patient presented in the first place, the apex was open. So I was wondering what is happening over there if the tooth is necrosed and the root has already been closed, and after that they have started the treatment. So I'm not sure.
So much for mentioning that. इतना बड़ा नाम और इतना बड़ा जर्नल देख के मैं बोल ही नहीं पा रहा था ये वाली बातें. इनिशियल रेडियोग्राफ के अंदर भी मुझे तो लगता है कि उतना ज्यादा ओपन एपेक्स नहीं है. फिर उसके बाद बिल्कुल दुरुस्त कह रही हैं कि देयर इज अ हिंट ऑफ अ क्लोजर व्हेन दे आर गोइंग फॉर द जीपी ट्रेसिंग. So yeah, there could be an X-ray angulation stuff on, because they are showing some CBCT images as well in which it looks pretty open. But then CBCT images in sagittal view, when you are, you know, moving from one plane to another, sometimes they appear open in one and they're closed in another, but I don't want to be too critical here.
So we have to basically assume. We can't 100% say what was the situation behind it, because it's not the original article of any author we are taking into account. So these are the things we have to just assume it. But it was a very healthy discussion, and I will appreciate next time more residents participate in this activity. And next month, we are basically assuming to have a case-based discussion related to endodontic case. So I will ask to volunteer any of the center from Karachi to show their case. So they can email to me or Dr. Faizan Javed written on the poster. If they are willing to participate within a week or two, then we will plan accordingly how we are going to decide the date and time for the next session on the basis of their convenience. So thank you, everyone.
As per the plan, we will have journal club of an article, alternately a clinical case. So a clinical case and a journal club in alternate fashion, so that we have at least 6 journal clubs and 6 clinical case discussion, right? So that this PAUDI session will have a good balance of research as well as a clinical thing.
Yes, the resident will also get the tips from their seniors, their experts of the subject. So I think that's a good forum. In future, probably the CPSP will ask the resident to submit their cases. So it's a good forum for them to present it and get the critique and get it refined. And documentation is also very important. So it's
and a constructive criticism so that all of us could get, improve our work.
Yes. And this also improves basically the documentation, and this is how we also can get published our small cases like we are discussing today. These are the routine cases we get encountered, and if we have a very good documentation, that can easily be published internationally or nationally.
Yes, agreed. Thank you.
Everyone, I would like to beg leave. You guys can continue. Thank you so much for the wonderful advice.
Thank you, Dr. Nasir. We are almost done. So thank you for
actually
joining
exceeded
us.
5 minute exceed. Yeah, so we should
thank you everyone for joining and taking your time. So probably we will meet you after a month with the case discussion.
Thank you. Allah Hafiz.
Thank you. Allah Hafiz.